Hey, Eric, welcome to the show.
Hello, Brittany. Wonderful to be here.
Oh, I'm excited to have you. How are you doing out there in San Francisco? Are you in a fire safe box right now?
Yeah, this is the what do they call that? That's the panic room. I'm kind of in the
Panic
panic room
room.
here in San Francisco, keeping safe from the virus and the fires and the riots. So yeah,
Oh my God.
I'm good. I'm safe. I'm sound.
Yeah.
I'm in a sound isolation booth. I could be in a game show right now.
Yeah, or a horror movie,
Or a
right?
horror movie. You choose your pick, right? Or maybe we'll just blend the two genres together.
Yeah, well, I'm in my panic room too, my dining room, because Hurricane Laura is coming. So
Right.
we're all just from all the sides, all the sides. Let's just talk about
Fantastic.
women's health and wellness and just forget about the world. That's what I love to do.
I'm in.
You know, well, our listeners love to learn about our guests, not just what they're currently working on, but where are you from? What did you study? And then how did you end up here? So give us some background about who Eric is.
Sure. I am originally from the East Coast. So I was born in New York City, raised in Pennsylvania, right on the border of Jersey. Both my parents worked in healthcare. My dad was a general surgeon. My mom was an ER nurse. Um, I studied bioengineering at Cornell as an undergrad. After 4 years in upstate New York, beelined it out to California, as anyone who lives in upstate New York might be trying to get out of upstate New York from a weather perspective. I did a PhD at UCLA in biomedical engineering, studying what's called MEMS, so micro electromechanical systems, these little kind of devices, little micro machines, if you will, made out of silicon. Graduated in 2008 when the world was collapsing. Figured I could either, sell oranges on the side of the road or work as a bartender with my PhD or go do a postdoc. So I moved to Europe and worked at a company called IMEC. It's a Belgian-based company, really interesting center. It's an advanced R&D center. They made their name in the semiconductor space, enabling Moore's Law, but developed a lot of application-focused research in a number of different areas. And I worked in their healthcare business line. And their healthcare business line spanned everything from point of care diagnostics, next gen sequencing, which I'm sure you'd appreciate, all the way through mobile health and remote patient monitoring. Eventually switched into business development and got out of the pure scientific domain and more on kind of the business and the relationship side. Eventually moved to San Francisco, where I currently live, and got really interested in healthcare, the convergence of consumer medical markets, the technology that would enable delivery of future prenatal care. And it was while working in business development that I met my co-founder. We had a bunch of ideas of what businesses we may or may not want to start. And from there was birthed Bloomlife. And here we are a short 5 years later.
Cool. Oh my gosh, that's awesome. I really love how you said, I took my PhD engineering medical background and then merged it with business, because I truly think that's the future of healthcare, right? Like the future of healthcare is no longer just here's a therapeutic drug that some scientist made and some doctor is going to administer. It's patients are taking their health into their own hands. They're at home testing themselves, and they are bringing data to their doctor via Skype or in person, And so I do think that involving the patient and their lifestyle and just consumer buy-in to their own health is it's like Fitbit started it, right? Like, hey,
Yeah.
track yourself,
Yeah. And that's really, and that's kind of one of the insights that we had. The company I was at, they had been developing advanced wearable technologies from even before Fitbit existed. They were developing the underlying sensors that go into Fitbits that were really designed to power next gen wearable devices. And they were really just way ahead of the market. They had the Basis watch for anyone who's old school in the wearable space. They had the Basis watch before Basis existed. They had the iRhythm patch before iRhythm existed. They had these EEG headsets before the companies that are now have been working this space existed. And they were trying to sell into these large corporations that are slow movers, right? They were like, what's this wearable space, remote patient monitoring, when really all the action was in startups. And while I was leading business development for them here in the US, I found that had these underlying technologies, and I was going and building business partnerships to license these technologies to do joint development projects with, a medical device company, and then turning around and taking the exact same technology and licensing it out to a consumer electronics company. And that for me kind of like stuck on my head. It's like, okay, this is two very different markets using the exact same technology. And ultimately what that meant to us is that there is nothing that really separates at a technology level a consumer product from a medical device anymore. These are the same thing. And the only difference is the population you're serving, the customer you're serving, the amount of validation and regulatory process you may need to go through these things. But ultimately it's the same technology. And the profound thing that stuck with us is that these worlds are converging, consumer medical are converging. And what that meant is that a consumer product or product designed for a quote unquote consumer can capture medically relevant data, which would rapidly accelerate discovery, innovation, and bring new insights into areas that have been largely understudied.
I freaking love it. Yes, totally. And, for our listeners, some of you are early stage founders, and you may be in a situation that I see oftentimes, which is a founder has a product that technically can be sold to a consumer, but can also be used by a doctor. And what this founder is doing is trying to target both at the same time. And a lot of investors say, don't do that. You need to pick one. You got to either go to consumer or you got to go the medical route. And it's hard because a lot of times it actually requires both, right? It requires the at-home wearable technology to transmit data to the medical record for the doctor to observe, right? And so it's really tricky. And I'm interested to see how investors might change their mind as some people succeed in creating a consumer wearable and having doctors involved. Investors may see like, okay, well, you're going to have to do both. I guess I won't make you pick,
Yeah, it is. I mean, what you're, I'm laughing because it sounds like the conversation that we've had early on and continue to have.
See, okay, I didn't even know that. I knew it though. Yeah, that's what they all have.
It is hard, and I think if I'm, and I advise a couple companies in this space, I think it's I think you have various stakeholders if you're working in healthcare and developing the kind of technologies that we develop, right? Any kind of remote monitoring tool, inevitably one of the stakeholders is going to be the patient, or actually in any aspect of healthcare, one of the stakeholders is the patient, and then the role that they may play may be elevated or de-escalated depending upon various business models. But I think the question really comes down to, for me, as I'm kind of advising folks, is what do you actually want to do with this product, right? Like what is it intended to do? Depending upon what it's intended to do, how involved does that doctor need to be? And is that they already want to have this information? Are they bought into that? Or are you kind of trying to like plow new ground with them?
Yeah.
And that kind of directly impacts some of the regulatory aspects, right? And that will inevitably impact some of the business model aspects of who really is the person who's supposed to pay for this. Yeah. And I think the one thing that we've learned is that, it's easy to go direct to patient because you could get a sale. If you have a good product, patients will buy it. If you're serving need for those, they'll buy it. Oftentimes though, and again, we could talk about this in the context of Bloomlife, if you really want to scale something up, oftentimes you need someone else besides the patient to buy it, right? Yeah. And I think that has been shown pretty true in most aspects of health, aside from perhaps consumer kind of gadgets. And ultimately to have the impact you may want to have in the world, to be able to deliver products to communities that may not be able to afford products, you need someone else to be able to pay for it, and primarily insurance companies.
That's right. Yeah. So for our listeners, when you're creating a startup or a business, you always need to figure out who's paying you. And when you get into healthcare, sometimes that can be tricky because you can have the consumer, the person, an individual, right? You can have the insurance billing it. You can have the doctor actually having to pay out of pocket to have a device in their own office, like an optometrist office or whatever, right? And then sometimes it's blended. Sometimes I know one medical device, it's for knee rehabilitation. It's not FemTech, but whatever. Their business model is actually that they rent out these braces to people, so it's like a rental. So There's like all these different models that you need to consider. Well, obviously you and I could have long philosophical talks about entrepreneurship and technology, but let's get into Bloomlife. What is Bloomlife?
Sure. So Bloomlife, we're a women's health company, and what we've been working on developing is really the future of prenatal care. When we started the company, we had been working in the connected health space for a while, and we saw that there was a lot of sort of challenges in this area. Access to care. There's over the past several decades, there's been an increasing rate of high-risk pregnancies. At the same time, access to care is becoming a problem in the US as well as in other parts of the world. There's a shortage of OBGYNs in this country. And so 50% of US counties lack any obstetric services. And so women oftentimes have to travel well over an hour to go get basic prenatal care. C-section rates are twice the rate of what the World Health Organization recommends. And really the bigger problems in this space that oftentimes stem from this increased rate of high-risk pregnancies being preterm birth, we just haven't moved the needle on this area. And so, for us, we started evaluating the space and seeing that, the way that we deliver prenatal care fundamentally has not changed in over 50 years. It's still based upon spot checks at the doctor's office, looking at a subset of known risk factors, using antiquated technology, a 5-minute conversation with the mom and she's out the door. And women oftentimes leave these appointments with more questions as they come in. Doctors are feeling rushed, pressured, are lacking tools to really meaningfully identify risk and address that risk. And for us, we saw there was an opportunity to really rethink what prenatal care might look like in the 21st century. By using the tools and technology that have existed in many other areas of medicine and bring them into the prenatal care space, to develop technologies to increase access to care for patients, empower women with information that might have previously been locked away in doctor's office or hospitals, and then through these technologies to start aggregating unique data to really build foundational knowledge over how do we do a better job of stratifying risk, how do we do a better job of tailoring care, and ultimately how do we do a job of improving outcomes. And so for us, what we're developing is a remote patient monitoring platform, as I show and tell here. So part of it is a device, it's a little sensor like that. It's about the size of a matchbox maybe. And then it connects into a patch. And so we're able to, like that. And so and the patch is worn on the belly. And we're able to non-invasively track various physiological signals of maternal fetal health throughout pregnancy. Things that are kind of currently used in medical practice today, such as contractions and fetal heart rate, as well as maternal health parameters that have been shown in scientific research to increase risk or decrease risk of adverse birth events. So chronic stress, sleep disorders, those kind of things.
Uh-huh.
And so by looking holistically at maternal and fetal health, we both provide feedback to moms and then help care teams over time to be able to identify risk, provide care outside the hospital, and hopefully start to improve outcomes.
Oh my gosh. All right. So this thing sticks to the woman's belly and it has this matchbox kind of sensor thing that's hooked on there, and it can sense all these different vital signs of the mom and the baby. Is just having this data actually going to move the needle on maternal mortality and C-section? Like how, first of all, does the data move the needle? Do you know that? Like,
yeah. So let's think about this. So how does the data move the needle? So let's take a mom, and again, we've had over 12,000 women use the product by now. And so take a mom who's in a rural community that may have a hard time getting into her doctor's appointment. We are able through technology to bring in a way the doctor to her, right? The same kind of appointment that she would have, the same kind of things the doctor could be checking, we can start to measure both through our device and then of course pulling in data from other devices. I mean, we don't need to measure blood pressure from this device. There's plenty of blood pressure cuffs out there. We don't need to reinvent the wheel. But so by being able to do things such as a non-stress test outside the hospital, which is where you're trying to assess fetal well-being, you can help the doctor assess, is everything okay with this baby? And if they're seeing problematic signs, they can have the mom come in for a more diagnostic test using like ultrasound. So you elevate care. That's for instance, one example. Another example could be a woman who might be she might be going into preterm labor, right? And we've had a lot of these cases where you help a mom identify she's having contractions, you help her time these contractions by providing an accurate, objective means of tracking these things. And especially in early early term, when the mom may not actually know she's contracting because the strength of the uterine contractions are less, you can provide awareness to her that I'm having more regular contractions. I should contact my care provider, and I should actually get into the hospital so they can intervene to perhaps head off an impending preterm birth. And so, yes, these things can really start to move the needle on outcomes. And our goal is to start building up that clinical evidence to show really specifically in very specific clinical use cases how that happens. But these are just some things that, for examples of how this could start to work.
Wow, this is super interesting. So you've said over 12,000 women have worn this. Have you noticed anything like surprising, or, like the data that seems to be the most valuable to doctors, or?
Yeah, so it's maybe it's helpful to provide some context. So our North Star has always been to rethink prenatal care. We believe the space is sorely in need of sort of a revisiting. For the most part, women have kind of been passive carriers of babies and not really active participants in their care, and that's kind of by design in many ways. And I think when you think about the shortage of care providers that we have, if you think about providing women with the ability to really better understand and manage things, I think you need to empower the mom to take a more active role.
I feel like the moms want to, though, right? The moms want to. The moms want to be proactive. That's 100%. Why there's mommy blogs and all these things, right? Because they want to be looking and learning and doing stuff, right?
They want to know. And I think that's something that, and by the way, from what we've seen, all moms want to know. And I think sometimes there's been the false perception amongst some folks in the clinical community that not all women want to know, or not all women can handle the information. I think this particularly pertains to high-risk pregnancies, where oftentimes doctors don't really talk about the risk of preterm birth because they say we don't want to scare the mom, or with low resource and low socioeconomic class communities, they say, well, they're not going to understand, or they can't handle this information. From everything we've seen, that's just not true. It's just not true at all. And by making sure the mom has access to tools, has access to information, she could both understand the why behind things, she can understand the what, and she could be a more active participant. She could actually be a contributing part to help manage her care, in many ways offloading that work from her overworked care team. And so for us, so that's kind of part of what we've been standing for. The other part has really been about how do you advance not just technology, because technology is great. I'm an engineer, I love technology, but how do you advance the fundamental science behind obstetrics, right? How do you actually build data, since in many ways, a lot of obstetric care is not very evidence-based today, and how do you start building those data sets? And so when we started, going back to a point you made earlier, we actually started by offering this product direct to patient, right? And it was really a product for mom to better understand what was happening, primarily focusing around third trimester, tracking and timing of contractions, and monitoring of maternal stress. And it was really a product for her. And she could use that information to then kind of further communicate with her care team as needed, but we were not integrated into the electronic medical records at that point. And what we learned from these things with all these women is we weren't serving the population we thought we were going to serve. So I think anytime you think of a wearable device and technology, you think, high income techie women living in, coastal cities or in the big cities. And we didn't find that. What we found is about 45% of our users were from rural communities. And that was kind of blew our mind. But in many ways, it kind of makes sense, because these are the ones that oftentimes lack tools or have an increased sense of they're a little more nervous about being far away and want something to provide information for them to make the right decisions.
Yeah, definitely. And listeners, that's one of the things you got to think about when you're designing your product and thinking about who your customer is that sometimes it's not your paradigm woman, right? And oftentimes, Bloomlife is doing great, and it's a rural woman. So that's something to absolutely be considered. And I love the social impact of that, right? These women that don't have access to doctors are eager to get the data about their pregnancy.
Yeah, that's exactly right. And a lot of it comes from, as you get the product out in the world, going and finding out who your users actually are, like going and talking to them, understanding the ones that are having great experiences, talk to the ones that are having difficult experience with the product, and learning as much as you can about who they are, what motivated them, what they're looking to get out of the product, what else they would like to see. And yeah, we found that, 45% were moms in rural communities. Over 35% were women that were high risk, which kind of speaks to a similar kind of level of concern. And then the other thing we really learned, which was interesting, was around really what's behind the data, like what you can do with this data. And so part of what we've been aiming to do is build a very large longitudinal physiological data set and start to apply machine learning to this data set to see, can we actually identify signs that will allow us to predict things in pregnancy, such as an impending birth. And so we've made some really great headway in developing digital biomarkers with this, to our knowledge, largest data set in the world on pregnancy, especially on the physiology of pregnancy in the third trimester. And that's been incredibly exciting. We got some pretty cool studies going on with that stuff.
Eric, this is really cool. The scientist in me really likes this.
Yeah, I figured you'd like to geek out on that stuff.
Yes, largest data set. I love it. So often we have FemTech founders come on here and they say, cervical fluid is really important for fertility. And I say, how and why? And they say, well, actually, no one knows. And that's why we're made this med device to figure it out. Or, there just again and again where they say, we know something is important for women, like prenatal care, important. But when you get down under and you say, okay, well, like what exactly and how and why, everyone's like, ooh, actually, we never measured it. Like, oops,
right.
Like we don't actually know.
Right.
So that's what I'm hearing you say is like, yep, prenatal care, really important. No one's monitored it on a daily basis via the mom's belly at home,
Right. Yeah. And I think we got some really good working hypothesis over like how, for instance, how you can move the needle on something like preterm birth. Preterm birth is a complex disease, has many etiologies. And what our sort of hypothesis is that if you really want to move the needle, you're never going to eliminate preterm birth. Like that's like saying, let's eliminate cancer. Like you're never going to eliminate cancer. The question is, how do you actually reduce the impact of someone who develops cancer? How do you catch it earlier? How do you intervene? How do you prevent it? And so for us, where we look at, if you look holistically at all the known risk factors for preterm birth, can you then create a care plan that incrementally lowers risk across each one of those facets? And in doing so, lower the overall risk of preterm birth such that like you could delay it so it's late enough that it happens that the impact is much less, the cost is much less. And so we looked at a lot of the underlying literature around what is known in these conditions around preterm birth amongst other areas, and seeing what would you actually want to know, what would you want to monitor, and then how do we collect that in the most seamless way for the patient, and then how would we ultimately integrate that into a clinical workflow so the doctor has things that they can then inform care back to the patient.
Yes. That makes sense to me, walking me through that. Like, here's the experimental design, right? We're going to collect this data and we're never going to like cure preterm birth, but we're going to have the signs and the protocols to like help make it not as terrible. What about stillbirth and C-sections and maternal mortality? How does collecting this data going to move the needle on those?
Yeah, so let's start with well, I know with stillbirth, since that's I think the probably the furthest away, and then kind of and even just think about maternal mortality. So on some of the maternal mortality things, one of the primary reasons for maternal mortality relate to hypertensive disorders.
Okay.
We're not measuring blood pressure with this device, to be clear, but we can integrate in blood pressure data. Part of what you start to think about is right now, if you have a mom who either is a high-risk pregnancy, has hypertensive conditions, they might say, okay, well, come in and we're going to measure blood pressure more regularly, or take your blood pressure once a week. Why once a week? Why once a week? That doesn't make any sense. If you have the blood pressure cuff on, why not measure it daily? Why not measure it twice a day? And why not be able to use that data to truly understand what is normal for this woman? Because in the way medicine works today, it's all about population level averages. And really if you want to have personalized care, you don't want to care about the population level. You really want to look at individual level.
Yeah.
And you really want to probably look at individual level to determine a deviation from that mom's normal line. And so by having a larger data set of looking at base blood pressure, for instance, throughout, you might be able to earlier identify signs that this mom is going into an increased hypertensive condition, right? Or by having tools that the mom is empowered to manage on her own that really help to elevate when something could be problematic, you could help to flag to the care team sooner than when she gets completely preeclamptic and she's actually like, you know, it might actually have some more severe condition that could result in death. You could provide early warning systems with better data. Like, so that's kind of one potential aspect of the maternal mortality.
I love that, because I actually I have very low blood pressure, which is like pretty dope issue to have, right? Low blood pressure in America. But, you know, what happens is that, you know, I've had like dental work done or surgeries, and, you know, I can see my own blood pressure and they're like, wow, it's really low. And I have to say, like, I know I have low blood pressure. And then they say, you know, oh, it'll jump back up, and then I faint or something, right? And it's like, no, this is my normal is, you know, like, you should be concerned if it's that low. Like, you know, because it's like there's this paradigm of like, well, the national average is, and I'm like, well, that's not my average, you know, that's like exactly this is how my body functions.
That's exactly right. Yep, that's exactly right. And to kind of continue on your point around, because I think the C-section one's very interesting.
Super interested in this one.
Yeah. So for reducing the C-section, I think, again, that's an interesting one. So because we actually have a pretty exciting research project going on with a researcher out of Oregon Health Science University, Dr. Ellen Tilden, who's a midwife up there and a professor. The number one reason for unnecessary C-sections in the United States is what they call a labor dystocia or labor arrest. So they say the mom is in labor and then she stalls out, and so we then intervene. Now the question is like, well, how do they know what normal labor progression looks like? And so you love the science world. Maybe your listeners like the science stuff. So there was a curve that came out of the University of Columbia. From a study in 1950 that determined what normal labor progression looks like. And from this curve, they said, essentially looked at cervical dilation over time during labor. It was 500 women. Now, from a study design standpoint, it was 500 white women from the University of Columbia. 80% of those people were sedated during pregnancy, during labor and delivery. And
70 years ago.
Yes, 70 years ago. And from there, they said, this is what normal labor progression looks like. And if you're too slow, you mean you stalled out, therefore we should intervene. As you can imagine from a study design, this is not good.
Oh my gosh.
Yeah. And so part of what we're collecting is, again, first of its kind data to determine what is actual normal labor progression looks like.
Yes.
Can we actually identify different patterns of coordination of uterine muscle that indicate the different staging of labor? And and that's just like when you're in the hospital. And then as you think about it being from home, again, there's a lot of research, and Ellen Tilden has done some of this that looks at timing of admissions when you're in labor as it's related to unnecessary interventions. And again, there's some pretty good evidence that shows that if you go in too early in the latent stage of labor rather than active labor, you have a higher prevalence of C-sections. There's a lot of reasons to that. And so part of what we're hoping to be able to do is allow women to confidently and comfortably labor from home longer, having a tool that not only helps them understand how the labor is progressing, but could share that information back to the care team, including potentially adding in some fetal monitoring components, such that everyone feels comfortable that the mom and baby are safe. She could stay home longer, and eventually once she transitions into active labor, then she could come in and have hopefully a smoother kind of ride in the hospital.
This is crazy. Okay, so I guess it's you're planning on rewriting the model, right? Because you're the one tracking this new data. I'm assuming you're going to publish on it, you know?
That's right. That's right.
Do the women wear this monitor on their belly while they give birth so that you're tracking it all the way through?
Yeah, and the protocol that we're running with Ellen, yeah. So she'll wear it kind of regularly throughout the third trimester, and then when she goes into labor, certainly wearing the product during labor and all the way through delivery, with the idea that, you know, the way the product works is, so the current technology for monitoring pregnancy is a device called a cardiotocogram. It's the big belts they wrap around that everyone hates because they're uncomfortable. They're like hockey pucks, and they wrap belts around you. You have to be strapped down to like a bed. That device uses ultrasound to measure fetal heart rate, and then a pressure probe on the abdomen to measure contractions. It was a device developed in the 50s, has not fundamentally changed in, again, 70 years.
Jesus, apparently we just studied pregnancy in the 50s. We were like, cool. All right, we're good to go.
Yeah, they're like, yeah, we got it. We're good.
We didn't
That's
even know what
enough.
like genetic material was. We still thought DNA was like protein. So at that point, like,
Yeah.
oh my
So
God. Okay, go ahead. Sorry.
yeah, no, we measure electrical activity. And so we measure the electrical activity of the uterus, which is a muscle, the baby's heart, which is a muscle, and the mom's heart, which is, again, a muscle. And each one of these creates a unique electrical signal, which electrodes, these are little electrodes back here, on the back of our patch could pick up. And so beyond measuring something like contraction frequency, which is what the pressure probe picks up, we actually measure the coordination of the uterine muscle. So it's kind of like the difference between taking your pulse and like, oh, my pulse is, 70 beats per minute, versus like getting an EKG, which looks at the actual firing of the various parts of your.
Wow. That's insane.
Yeah. So the point being, we just get a lot more rich information with our device, which allows us to do things current technology cannot do.
Are C-sections bad for women and babies?
So C-sections can be life-saving, to be clear. Like sometimes C-sections are totally warranted. Sometimes C-sections are planned because the woman has placental previa and she can't go into labor, otherwise she risks bleeding out. But the evidence is pretty clear that unnecessary C-sections are not ideal. And perhaps not so surprisingly, right? I mean, nature's kind of figured out that this is the best way to deliver babies. So having unnecessary C-sections increase risk of maternal morbidity, either due to infection, injury. It has a higher incidence of some sort of fetal injuring the fetus, right? You're having major abdominal surgery. There's also increased cost. There's increased recovery time. So yeah, it's not ideal to have a high level of C-section rates. It's part of the reason why even ACOG and the payers have started shifting towards different models to try to encourage the reduction of unnecessary C-sections. It's a big problem, not just in the U.S., but in many other parts of the world as well. I think in like Brazil, the C-section rate's close to 50%. Like it's a pretty big problem in many parts of the world.
Wow. Yeah, that reminds me of like how doctors just prescribe antibiotics every time you have a runny nose. They're just like, here, take this pill, feel better, even though you have a virus, not a bacterial infection. What was the next question I was going to ask you is going to be, America has horrible rates of maternal mortality and preterm birth. Do you have a guess as to why America is horrible compared to other developed countries? How is your device gonna, I now understand how it's gonna help move the needle, but like based on America's specific issues, is your device gonna address them?
Yeah. I mean, the situation in the U.S. is pretty severe. U.S. ranks, if not last, then near last of all industrialized nations in birth outcomes. And I think the underlying reasons for that are kind of varied, right? I mean, as you know, healthcare is a pretty complex area, and I think there's never a silver bullet. I think the underlying reasons, if you think about it, are access to care, as already mentioned. If you don't have ready access to prenatal care, then you might be missing important visits and screening tests that could help identify risks sooner. And so 50% of the U.S. counties lack basic obstetric services. A lot of women just don't get in. Either when they should or as frequently as they should, and so a lot of risk is increased. There's also a lot of socioeconomic issues and social determinant issues. So the adverse birth events in the U.S. disproportionately affect women of color, to be clear. I think if you think about the socioeconomic situation that they're dealing with, there's a lot of underlying reasons, whether or not that's kind of poverty, homelessness, chronic stress, there's a lot of problems within there. And those are often folks that also have issues accessing care, right? If I'm in a low resource community, I may have other kids. I may live far away from the hospital. And sometimes I don't even live far away, but I work an hourly job and I just can't afford to go to my prenatal care appointments. And so they don't. Another thing that we've seen, because we've actually been doing some work with the Maternal and Child Health Bureau, thinking about how do you deploy remote patient monitoring technologies into underserved communities, right, to start to close these gaps. And one of the things we've seen, having done a lot of research and talking a lot with underserved communities of color, is that there's also a big trust gap that exists
Yeah.
oftentimes with the patient or their provider, is that they don't necessarily trust them, and because they don't trust them, they may not share things, and they may not go to their appointments. So there's, and a lot of times there's valid reasons why they don't trust them based upon their lived experience. And so for us, I think the way that we start to solve some of these things, because again, we think a lot about this stuff, is how do you make prenatal care more accessible to women, period, hard stop. And I think if you increase accessibility, that already is going to start closing those gaps. Another aspect when you start to think about accessibility is, again, how do you start to empower women with information and knowledge that help her understand what's going on, help her understand how her health is trending, help her understand the why behind things, so she can actually be an advocate for herself within her own prenatal care, and in many ways change the power dynamics between her and her care provider. And I think that's in many ways what some successful new models of care, such as centering or group prenatal care, have been able to show, that if you actually empower the mom, you're giving her more knowledge, you're decreasing potentially stress levels, you're increasing her confidence, and she feels like she has a more active role. And for whatever combination of these things are, it's improving outcomes. And the third thing is just around, again, having better data. If we have better data, then we hope to be able to show that better data can lead to earlier identification of risk, tailoring of care, and ultimately improving outcomes. And so I think it's a combination of things where we hope to move the needle. But it is a significant problem that needs to be addressed if we're going to, like, make this, make this space better for all women.
Yes. Eric, thank you so much for what you do and being mindful of that. Thank you. That's so important. That's why we have this podcast, because not just because I love talking about women's health and wellness, but it's because it's a really, really overlooked area where women are literally dying because we're not talking about it. So thank you for what you do. I wanted to ask you about fundraising. So you're a male FemTech founder. What has your experience been like, talking about women's, healthcare and fundraising? Have you been warmly received? Have you been questioned why you care? Have you got investment? How's that experience been like?
Yeah, all of the above. All of the above. I think the questions we got have changed based upon where the overall women's health has been, women's health space has been. I think it's changed based upon almost where my own comfort level has been, sharing some of the personal details from my own life about Bloomlife. And so, when we started, we started the company in 2014. We really kind of kicked it off full time in 2015. And back then, women's health was not a market. There was no such thing as FemTech. Like, there really wasn't. And I remember a lot of the conversations they had with investors over, like, starting a company in the women's health. They were confused. They're like, women's health is a niche market. If there's no business there, you should go after a bigger market, which again, dumbfounded me, given that women make up 50% of the population. And I think ultimately, I think the receptivity has changed. I think obviously there's more interest today than there's ever been in women's health. I think there's been some really great work from the broader media of shedding light on a lot of the massive problems and inequities in maternal health and prenatal care and the outcomes around there. There's just been some great journalism in this area. And I think for me personally, as a male, starting a company in women's health, I got interested in this area based upon some personal experiences that I oftentimes never shared, because frankly speaking, I think most founder stories are fake and made up. Maybe that's the cynical side of me. But they feel very forced, and mine's not forced, but I also didn't want to. I don't know. I just felt like I don't know. I just felt like I shouldn't have to share it. It should the business should stand on its own. But I have learned that it is important to share these things. And so I got interested in the space with struggles to start my own family. And my partner and I spent 7 years trying to start a family. Had a lot of miscarriages. Had a number of years of kind of failed fertility treatments. And I just got very interested in this area of fertility, pregnancy, early life, this journey that all of us have gone through at some point. Many of us will go through as adults, and how when you decide you want to start a family, how this becomes this massive driving force in your life where you will pretty much do anything to make it happen. And the fact is again, there's a lot of things we don't know about this area that I felt there's a lot of opportunity for us to apply, IMEC related things and knowledge in this area. And so as I've grown more comfortable sharing about my own experience, I think folks, especially, to be perfectly honest, women that have looked at me with a kind of the side eyes, like, why are you really starting this business? You're just trying to capitalize on women's fears. It's like, it really has nothing to do about that for me and for us. We just think that there's huge amount of need in this area. We, like you, I think we're big advocates of the women's health space in general. And we think that, doing good in this area of women's health can have massive long-term, massive long-term ripple effects beyond pregnancy, right? I mean, part of our belief is that if you want to drive widespread health change globally, start with moms.
Yes.
And that the best time to try to drive any kind of change in a woman's life is probably during pregnancy, when she's most engaged about her health, when she's most primed for behavior change, when she's doing something perhaps for the first time for something beyond her own self. It's for her family and for her child.
Yeah.
And so it's just a very exciting area to design around, and we feel fortunate to have been successful in raising some decent capital by really being able to partner with just amazing investors such as K4 Capital and Reinventors and Stardust Equity, some really great women's health investors out there that really care about the same things that we do.
Yeah. First, it's a shame that so many men have mansplained our own bodies to women, women's bodies to women. And so that leads, when you say that you care about uteruses and women's bodies, women unfortunately have this default, don't try to explain my body to me, and so we're on the defensive already. And so I can see why, you've got that look a lot. I'm ready with that look a lot of times as well. But I'm grateful to hear that you have funding. That's what we need to be talking about. We need to get the articles out. We need to talk about it. It is, people are getting funded. They are growing. And I love that you were finally, opening up about your story, because like it or not, pitching to investors is theatrics. It's about emotion. It's about this show. It's about putting on a show. And, when I had my DNA-based dating app, I always led off with I'm a hopeless romantic geneticist, and they were like, oh my God. And I always was getting asked, are you single? Which is absolutely inappropriate and has nothing to freaking do with my business model or my go-to-market strategy. But the investors loved it. And I would say, yes, I'm single and I can't wait to find my love using science. Give me your money. And then they did, right? And I hate that, but it's the game. And, that's what FemTech Focus is empowering founders to do, is to know how to play the game, because what's on the line is women's lives. That's what's on the line. So if we need to take a little bit of acting class, whatever we got to do, women's lives are on the line. Eric, I could talk to you forever. This has been so fun. I do want to ask you two last questions that our lovers love. Oh my God, our listeners love. The first is, lots of areas in women's health. Some are saturated and some no one's working on. So what's an area in women's health that you think still needs innovating?
Oh man, it's a good question. So if I'm looking at starting a company in this area, so people start companies for a lot of reasons. I think at some point, if you're taking external money, there's always a need to find an exit for investors. Mm-hmm. I would actually focus on areas that I think are pretty well developed in many ways, but that have not accounted for the women's health aspect of it. And so I would actually think about things like cardiac.
Yes.
I think cardiac is obviously is a very, very well and mature developed market, but I think there are very few, if any, companies that I know of that have really started thinking about that space from a women's health lens.
Yes.
And I know that traditionally, as companies have developed products and drugs, they have oftentimes looked at women as little men, just a little, the model as a little man.
Yeah.
It's instead of being a 6 foot, 200-pound person, it's a 5 foot 325-pound person or whatever. Yeah. And that's just not true, right? I mean, and women have a lot of, they're a harder model to study because of their cycle, right? And of the hormones that come into it. And I think if I would look into that area and see where can you actually address some of the cardiovascular needs of women thinking about it differently, because I think if you're successful there, you will find a big exit from one of the cardiac players, because there's a lot of them out there. So that's that's what I would suggest.
I love that answer. I love it. Yep. FemTech for us is anything that solely, disproportionately, or differently affects women. And there's a lot of cardiac diseases that affect more men than women, but when they affect women, it's in a different way. So
that's exactly right. Yep, exactly. And the mortality rate can actually be higher because of the way that doctors evaluate and treat women. And so, so, and again, there's a ready set of buyers. If you crack the nut on that one, there's a ready set of buyers for those kind of businesses.
Come on, heart people. Come on. Our last question for the interview is, what do you think FemTech industry as a whole needs the most right now in order to be successful?
Oh, yeah, that's another good one. So I think what's needed to be successful, I think we need to have a lot of collaboration between the women's health companies. There's still few and far between of us. It's a pretty small world right now. And I think collaborating, and not just collaborating like, oh, we have a partnership, we're doing business with each other. I mean, collaborating like sharing what's working, sharing what's not working, sharing great investors with each other, sharing great partners with each other. There was a really great event I was at last year called the Women's Health Innovation Summit. And it was a totally different dynamic of an event than I've ever been in, primarily because it was like 90% women. And it was so much more open and collaborative than like a lot of the like regular tech events, which is like, we're dominating the competition and we're crushing this, we're crushing that. There were like, there was a lot of humility. There was a lot of honesty over what actually they were encouraging and problem. And so I think that's one of them. And I think what comes out of there for me is two other things. One of the things, I think the biggest obstacles for women's health companies is the ad networks. The ad networks do not allow a lot of women's health companies to advertise the way they do other products. And that is a huge problem. Google and Facebook block, when you talk about the uterus, you talk about breasts or vaginas, they block those ads. And that cuts you off from the biggest area to find customers and for customers to find you, which directly impacts your ability to grow and scale your business, which directly impacts your ability to raise capital. And so I think there needs to be a really concerted effort in collaboration amongst the various industry players to go and get in front of these ad networks and say, you got to change your policies here. These are not fair. And I think that's something that could seriously move the needle. And then the third thing I'd say is we need to see exits. I think there's a lot more investment in women's health than there's ever been, but what truly validates the space more than anything is actually exits. And I think we started to see some really good ones, some, several $100 million exits in some areas. And I think we need to see more of those. And success begets success, and you're an investor, so you know that. And so I think once you start to see some of these things start to unblock themselves and start to see some liquidity events, I think you're going to see a lot more people piling in, and not just at the early stage, but I think at the later stage, which is oftentimes where women's health companies have struggled, because there's a lot more like seed stage women's health investors. There's still very few late stage kind of growth stage investors that they're really looking at the space and deploying dollars.
Eric, I cannot agree more with everything you just suggested. And it gives me validation for all the things I preach on this podcast. I'm like, good. Other people are saying it. Good.
Yeah, keep carrying the torch.
I will. Thank you so much for your time today. I really appreciate all that you're doing for women's health.
And thank you, Brittany, for all you're doing as well, for building the audience, for driving awareness. Look forward to talking again sometime soon, and hopefully meeting in a post-COVID world.
Yes, definitely. Bye.